Welcome to the deep dive. Today we're tackling a really pivotal piece of research. It aimed to settle a major debate in treating severe leg ischemia.
Yeah, a really important one.
Our mission is to understand the lasting impact of the BASIL trial, that's BASIL, which stands for Bypass versus Angioplasty and Severe Ischemia of the Leg.
Quite a mouthful, but yeah.
We're going to unpack how this study influenced, how doctors approach patients who are suffering from severe leg pain even at rest, or ulcers, or even gangrene because of blockages below the groin.
We'll be digging into the original 2005 publication in the Lancet, mainly, plus some expert commentary that really highlights why it's still so relevant.
Right. To really get why BASIL was such a game changer, we need to set the scene a bit first.
Definitely. What was it like before BASIL?
Well, before this trial, if you had severe leg ischemia, the standard approach was usually surgery, a surgical bypass using one of your own veins.
The traditional way.
Exactly. But it's a big operation,
Yeah.
It has risks. And sometimes, a suitable vein just wasn't available.
Or the patient was too frail for major surgery.
True. So endovascular therapy back then, mostly balloon angioplasty, was coming up as a less invasive option.
Yeah, less invasive, yeah. But the big question was, how well did it actually work long-term compared to the surgery?
That was the unknown. Earlier studies had looked at it, but they often had limitations. Maybe they looked back at old records or were quite small.
Retrospective, yeah. Or sometimes they included patients with less severe disease, which muddies the waters a bit.
So BASIL was designed to give us much stronger evidence.
Exactly. Much more definitive to really guide those treatment decisions.
Okay, so let's dive into the trial itself. What were the kind of nuts and bolts of how they ran it?
Well, BASIL was, as you said, pivotal because it was a multi-center randomized controlled trial, RCT.
The gold standard.
Pretty much, yeah. Especially for comparing treatments like this. It helps minimize bias because patients are randomly assigned, and this was across 27 hospitals, all here in the UK.
Okay, 27 centers. And how many people actually took part in this comparison?
They managed to enroll 452 patients. All of them had severe limb ischemia, and it was specifically due to problems below the groin, what we call infra-inguinal disease.
And these 452 patients, they were then split into two groups.
Randomly assigned, yeah, to one of two initial treatment strategies.
What were those two strategies they were comparing directly?
Okay, so one group got a surgery-first strategy. The plan A was a surgical bypass operation.
Right.
The other group got an angioplasty-first strategy. So the first attempt to fix the blockage was with balloon angioplasty, a less invasive catheter-based procedure.
Got it. Now, who could actually get into the trial? You mentioned specific criteria earlier.
Yeah, and this is a really crucial point. To be eligible, patients had to be considered suitable for both options.
Both surgery and angioplasty.
Yes. A vascular surgeon had to say, yep, surgery is feasible, and an interventional radiologist had to agree that angioplasty was also a reasonable shot for that specific patient.
Okay, so they needed that consensus. Were there reasons someone would be excluded?
The main one was if the blockages were higher up, above the groin, supra-inguinal disease. They weren't included. The focus was strictly on problems further down the leg.
Makes sense. So what was the main outcome they were measuring? The primary endpoint?
The primary endpoint was something called Amputation-Free Survival, AFS.
Amputation-Free Survival. What does that mean exactly?
It basically measures the time until one of two things happened. Either the patient needed a major amputation, meaning above the ankle on the leg being treated, or they died from any cause. Whichever occurred first stopped the clock for that outcome.
Okay, so it combines keeping the leg with staying alive, a pretty crucial combined measure.
Absolutely. It reflects both limb salvage and overall survival, which are key goals here.
And apart from that main goal, what else were they tracking? Secondary endpoints?
Yeah, they looked at quite a few other things. All-cause mortality just on its own. Complications or deaths within the first 30 days, that peri-procedural period. They also tracked whether patients needed more procedures later on to keep the blood flowing re-interventions. And patient-reported quality of life, plus a detailed cost analysis.
Okay, quite comprehensive. So the study gets going, patients are treated. What did the initial results show, say, after the first 6 months or so?
Well, the initial findings looking out to about 6 months actually showed no significant difference, statistically speaking.
No difference in that main outcome. Amputation-free survival.
Correct. Between the surgery-first group and the angioplasty-first group, the curves were pretty similar early on.
Huh, okay. That might have surprised some people, maybe. What about those other outcomes, the secondary ones? Any differences there in the short term?
Yes, there were some notable things. The surgery first group, they did have a higher rate of morbidity, more complications,
Like what kind of complications?
mainly things like wound infections, issues at the surgical site, and also cardiovascular events like heart attacks.
Okay. But you said no difference in deaths early on?
Right, no difference in 30-day mortality. That's important. But on the flip side, the angioplasty-first group, they needed more procedures later on.
Ah, more re-interventions to keep the arteries open.
Exactly. The initial fix maybe didn't last as long or needed touching up more often.
And quality of life. Cost.
No difference found in health-related quality of life at that early stage, but cost, yes. The surgery-first approach was definitely more expensive initially, about a third more in that first year.
Okay. So, summing up the short term, angioplasty looked maybe less risky up front, cheaper too, but needed more follow-up procedures. Surgery had more immediate hurdles, but perhaps was more definitive initially. But overall, similar amputation-free survival at 6 months.
That's a good summary of the early picture, yeah.
But often with these treatments, the real story unfolds over the longer term, doesn't it? What happened when they followed these patients out further?
Exactly. And this is where BASIL gets really interesting and maybe a bit more complex. The initial planned analysis, looking at 1 year and even 3 years, it still didn't show a statistically significant difference in amputation-free survival.
Still no clear winner based on the original plan.
Not according to the pre-specified primary analysis, no. But the researchers then did what's called a post hoc analysis.
Post hoc meaning after the fact. Looking at the data in ways not originally planned.
Precisely. You have to be cautious with these analyses because you might just be finding patterns by chance, but they can generate important hypotheses.
Okay, so what did this post hoc look suggest?
It suggested that if you looked beyond 2 years, a difference started to emerge. It hinted at a benefit for the surgery-first approach compared to angioplasty-first.
A benefit in what sense?
In both amputation-free survival and overall survival, just dying from any cause.
Wow. So better long-term survival and limb salvage potentially?
Potentially, yes. The numbers they reported, the hazard ratios, were quite striking. For amputation-free survival beyond 2 years, the hazard ratio was 0.37 favoring surgery. For all-cause mortality, it was 0.34.
And hazard ratio less than 1 means lower risk, right? So significantly lower risk.
Yes, significantly lower risk of having an amputation or dying, or just dying, in the surgery group after that 2-year point, according to this specific analysis. The confidence intervals were reasonably tight, too, suggesting it wasn't just random noise.
So despite the similar short-term results, this deeper dive hinted that maybe surgery offered better long-term protection for some patients. But crucially, this wasn't the original main finding.
That's the key caveat. It wasn't the primary analysis result. It's an observation from looking longer and differently. They also noted, by the way, that the surgery patients did spend more time in hospital, especially in higher-level care during that first year.
Right, reflecting that bigger initial hit from the surgery itself.
Makes sense.
Okay, so BASIL produced all this data, stirred up discussion. What really makes it stand out? Why is it still considered such a cornerstone study?
Well, I think the expert commentary really nails this. BASIL is still, even now, the only published trial giving us level 1 evidence.
Level 1, the highest quality.
Highest quality, yeah. From a randomized controlled trial directly comparing endovascular therapy versus surgical bypass for this specific condition, severe limb ischemia below the groin, nothing else like it has been published since.
And why was that direct comparison so vital back then?
Because there was genuine uncertainty, real equipoise, as doctors call it.
Equipoise meaning they honestly didn't know which was better?
Exactly. Surgery was established but risky. Angioplasty was less invasive. Technology was improving fast, but its long-term durability was unknown. Doctors needed good evidence to guide them, especially for these really sick patients.
And that post hoc finding about the long-term advantage for surgery, how did that influence thinking?
It really made people think about durability. Maybe angioplasty was a good initial step, especially for less fit patients or those without good veins, but perhaps surgery, if feasible, offered a more lasting solution against the worst outcomes, amputation and death down the line.
Interesting. And you mentioned something about vein versus prosthetic bypasses.
Yeah, that came out of later analyses of the BASIL data too.
Yeah.
It strongly suggested that if you had surgery, using the patient's own vein for the bypass graft led to much better outcomes than using an artificial prosthetic graft.
Okay, now we have to talk limitations. Every study has them. What should we keep in mind when looking back at BASIL, especially now?
Oh, absolutely. And this is critical. A major limitation is the technology used. The endovascular arm was almost entirely plain old balloon angioplasty.
Just stretching the artery open?
Pretty much. Since 2005, wow. Endovascular tools have exploded. We have stents, drug-coated balloons, drug-eluting stents, devices to remove plaque. Atherectomy.
So the angioplasty done in BASIL isn't really what patients would likely get today.
Not necessarily, no. Today's endovascular results might be significantly better. Operator skill has also improved massively. That's a big one.
Makes sense. Any other major limitations?
The other really big one is generalizability. Remember that strict eligibility criteria suitable for both treatments.
Right. Only about 10% of patients screened actually got into the trial.
Exactly. So were the findings from that highly selected 10% applicable to the other 90% of patients with severe limb ischemia? That's always been a question mark.
So considering those limitations, the tech advancements, what's the relevance of BASIL for doctors and patients today?
It's still incredibly relevant, surprisingly perhaps, because it remains the best direct comparative evidence we have between those two initial strategies.
Even with the older tech.
Even with the older tech. The consensus now, largely influenced by BASIL, especially that long-term signal, is this. If a patient has a reasonable life expectancy, say, more than 2 years, and they have a good quality vein available for bypass,
Surgery should be strongly considered.
then open surgical bypass should be strongly considered as the primary treatment. That post-hoc finding about long-term survival and limb salvage carries a lot of weight for those patients deemed fit enough and suitable.
So even with fancy new minimally invasive kit, the potential long-term durability shown in BASIL for surgery in the right patient, that still resonates.
It absolutely does. And, beyond the specific results, BASIL really pushed the whole field towards evidence-based practice for limb salvage. It set a standard.
Okay, let's try and pull this all together then. What's the main message for someone listening to our deep dive on BASIL?
I think the key takeaway for you is that BASIL showed pretty similar outcomes in the short term between starting with surgery versus starting with angioplasty, but surgery cost more initially and had more early complications.
Got it.
But that longer-term analysis, even with its caveats, suggested that for patients likely to live longer than a couple of years and who have good veins, that upfront surgery might offer better protection against amputation and death further down the road.
So a trade-off between short-term risks and costs versus potential long-term gains for the right patient group.
It sums it up well, yeah.
And its overall significance. Why do we still talk about it?
Because despite all the incredible advances in endovascular tech since 2005, BASIL is still foundational. It provides the highest level of comparative evidence we have to guide that crucial initial treatment choice in severe limb ischemia. It's a cornerstone.
It really is a fascinating look back at such an influential study. And it does leave you thinking, doesn't it? With endovascular technology having leaped so far forward since BASIL, what kinds of big long-term studies do we need now to really figure out the optimal strategies for today's patients?
That's the million-dollar question, isn't it? How do modern techniques stack up long-term?
It definitely shows how medicine keeps evolving. Thanks for joining me for this deep dive.